to this month's Center of Excellence in Hematology Meet the Expert seminar series. I'm going to take a minute to just remind you about the Centers of Excellence in Hematology, and I'm going to share my screen to take you to a couple of sites. First of all, let me get my screen shared. So this is our home website. Hopefully you can see this, and I remind everybody every month that we do this. We have upcoming events announced here. So our speaker today is Stefano Rivella from the Children's Hospital in Philadelphia. But at this same site, you can actually come in and find lots of information across here, including the different centers that are supported. And for example, the core facilities that they provide that are available to anybody for utilization to perform the research that they need to. And you can find that information here at our home website. We also announce funding opportunities that are available. There are type A and type B P&F programs. Right now, type A programs are a totally open rolling opportunity to get credit at core facilities for performing your research. And we cycle the type B announcements and awards 2 or 3 times a year. So keep your eyes posted for that if you're interested in looking for some funding opportunities. These are really set up predominantly for new investigators, postdocs, and things like that who are up and coming and doing research in the non-malignant hematology. So I want to just encourage you to go to those sites and check out those opportunities. And also I want to just remind you of one other thing in this Meet the Expert seminar series, where today we will be hearing from Stefano Rivella. You can actually find that information here, but you can also find recordings of previous seminars at this site, and you can click on those and hear about those. Some of those are not posted yet because of sharing of unpublished data, but you can periodically look in here and find these updated. So I want to encourage you to do that. And I will stop sharing right now and take this opportunity to introduce Stefano Rivella. Stefano comes to us from Children's Hospital in Philadelphia. He got his bachelor's degree and Ph.D. at the University of Pavia. Is that okay? Want to make sure I'm saying it right. Now this one I should have asked, in the lab of Dr. Toniolo. Is that close? Okay.
Perfect.
Great. And as far as I could tell, you studied transcription off of the X chromosome. Is that right?
This is, yeah, human genome and gene structure.
Okay. I want to also forgot to invite all of you to mute yourself, but I'm happy to go through and mute you. Thank you. Okay. Stefano then went on to Memorial Sloan Kettering, where he did his postdoctoral fellowship and began his work on studies in beta thalassemia and therapies for beta thalassemia. He then joined the faculty at Weill Cornell, and then is now located at the Children's Hospital in Philadelphia, where he's a professor in pediatrics, and he is currently now I'm going to totally mess up this name, but I'm going to give it a try. Kwame Ohene Frimpong Endowed Chair in Pediatric Hematology. That's very phonetic and maybe completely wrong, but we want to welcome you today. And today, Stefano will speak to us about gene therapies for hemoglobinopathies. And I'll let him take the screen at this point. Are you on? Can you? Let's see. There. Are you muted? Or are you okay?
So can you hear me now?
Yes.
Okay. So the only thing is that I don't, let me see that. I have a problem in sharing the screen right now. I don't, oh, here we are. Sorry. It just
Not a problem.
Moved to a different. Okay, I think, okay, let me try again because I think I'm seeing your desk. Is that possible?
Right. I think I unshared my screen. Let me just flip back and then I'll flip it again and let you try again.
Yeah, I see. I don't see my my PowerPoint. I was seeing this before.
What are you currently viewing? We did it fine before. I'm not sure.
You know what happened is that no, it's my fault. My software closed the PowerPoint. That's why. It's gonna open again.
Great.
My bad. My bad. Sorry. Okay.
Not a problem.
Here we are. Okay. Can you see it?
Yes, we can
Okay,
see it.
wonderful. Oh,
I
wonderful.
want to remind people that if they have questions, populate them in the chat and I will monitor them for inviting you to ask your question. And welcome and thanks everybody for your attendance.
Okay. So Diane, thank you so much for inviting me to give this presentation. Today, I'm going to talk about a variety of approaches for treating hemoglobinopathies, including alpha thalassemia, and that's the part that is unpublished, and I will discuss in the second part of my presentation. So I want to start showing my disclosures. You know, for my gene therapy work, I do have a relationship with a company called Mera GTX, in the sense I'm on their SAB, but I didn't receive any source of money from them for the work I presented today. And everything was supported by federal grants and NIH. So I want to start talking about you know, the structure of the beta globin, the globin genes. So we know that both the beta globin genes and the alpha globin genes are expressed on different chromosomes, and they're expressed at different level during development, such that, for instance, before birth, the gamma globin gene is expressed at high level, and after birth, in the next 3 months following birth, the gamma globin gene is suppressed and the beta globin gene is upregulated. In the case of alpha globin gene, they are pretty much expressed very early on during development. And so this makes a big difference, because if you have mutation in the beta globin gene, normally children are asymptomatic in the first 3 months of life. But if you have severe mutation in the alpha globin gene, like complete absence of the alpha globin gene, you may have Barth hydropsis fetalis syndrome, where basically normally the children die in utero. So again, there is a variety of mutation, and I will not discuss too much in this slide the alpha globin related mutation, because you know, I'll introduce it later. But basically, all this mutation in the beta globin gene or the alpha globin gene can lead to abnormal hemoglobin, such as in the case of sickle cell anemia. We have a single point mutation that modifies completely the qualities, I would say, of the globin, the adult hemoglobin, such that cells sickle, with all the consequences that we are aware of. In beta thalassemia, normally the mutation reduces the synthesis of the beta globin gene, such that there is a reduction and insufficient production of hemoglobin, and there is also concomitant production of hemichrons that, you know, basically aggregates alpha globin and heme, and these are very toxic and affect cell viability, but also cell cycle of the erythroid progenitors. And then in alpha thalassemia, we'll see more complicated, but again, mutation can lead to a reduction of the alpha globin gene synthesis. And then we have, in this case, a reverse situation where we have an excess of beta globin chains. So hemoglobinopathies are very important from the perspective of their distribution and social impact. We have many, many patients worldwide, and many of them are also now in countries where normally you know, thalassemia or beta thalassemia, alpha thalassemia were not present because of immigration. Historically, the thalassemias are associated to malarial endemic regions, because carriers can somehow are protected from the infection from malaria. And the great news that today there was a vaccine that may be going to be utilized to help many kids in the world for fighting malaria. But anyway, the bottom line is that this has been malaria and probably thalassemias are some of the most ancient diseases, because as long as malaria was present, probably there was a pressure to introduce some mutation that allow people to survive. So in terms of gene therapies, basically there are two main strategies to try to cure these diseases. One is called gene addition, and here's basically a schematic approach. How does it work? So basically, in the present technology, basically requires introduction of a wild-type copy of the gene, for instance, a beta-globin gene, into a viral vector, and mostly these are lentiviral vectors. And basically, the goal is to introduce this corrected copy of the beta-globin gene or alpha-globin gene, as we'll see, into hematopoietic stem cells ex vivo, and then introduce back the bone marrow or hematopoietic stem cells into the patient. These are autologous bone marrow cells, so we don't have to, we don't need to look for allogeneic bone marrow transplant and a specific donor. The advantages of these approaches are obviously that whatever gene we introduce in these cells is generally independent from the mutation, so we can cover a large spectrum of mutation with this approach. And in some cases, we may need to overexpress the gene to really achieve a therapeutic level, and this may not be sufficient in some diseases. I'm not going to talk about metallochromatic dystrophy, for instance, which can be cured by gene addition, but simple addition of the gene without overexpression is not sufficient, apparently, to cure the children. The cons of this approach is that we are aware that this leads to random integration, and in some, depending on the system you're using, the vector that you're utilizing, this may require high vector copy number, like a high integration per genome, and these obviously, because of the random integration, can lead to an increased chance of genome toxicity. So gene therapy for thalassemia and sickle cell anemia are a reality. These are 3 papers from 3 of the major trials that have been described so far, led by investigators in France, in Italy, in the United States, with different approaches. But basically, these are lentiviral vectors that transfer a corrected copy of the beta-globin gene or the gamma-globin gene in the attempt to cure sickle cell or thalassemia. And many of these patients so far have been treated successfully, such that they're not, for instance, transfusion dependent anymore. Even if not, but with the caveat that not all the patients reach complete therapeutic levels. So the alternative ways to do gene therapy for thalassemia is through genome editing. So, there are a variety of tools, CRISPR, zinc finger nucleases, talents, etc. And one approach is basically to introduce a CRISPR protein together with a guided RNA and introduce a double strand break. And this is apparently has been very successful in, again, in sickle cell and thalassemia, because as we'll discuss later, there is a specific gene called BCL11A. And if you target a specific erythroid enhancer and disrupt the expression of this gene basically you limit its expression in erythroid cells, it can reactivate fetal hemoglobin. Another technology that's not yet in clinical trial, but very promising, is base editing. These on paper would be even more potentially safer, because these, and I'm not going to discuss the details of the component of this approach, but basically they're still based on a Cas9 protein, but it's been modified to be introduce a single cut in one single strand of the DNA. And with a guided RNA, again, in this case, the goal is not to open the DNA as a double-strand break, but really to try to repair the single point mutation. And this also potentially is possible. And there are recent publications that show that correcting the mutation in patients from sickle cell anemia could be possible. So the pros is that the gene disruption is very efficient. There is a trial led by CRISPR Vertex that showed that now a variety of patients have been treated both with thalassemia or sickle cell anemia, reaching high level of fetal hemoglobin expression. There's been recently a case hemophagocytosis in one of these patients, but it's not clear if this is related to the bone marrow transplant per se or by the use of the vector. The potential cons of this approach is that the few publications, several publications here, I'm just showing a couple of them published in the last 2 years. One is the fact that targeting cells with this approach requires cell cycling, and apparently, at least in vitro, has been shown that there is a sort of selection for also for the mechanism per se. There is a selection for cells that may not express p53, and this may also, concern, because we may select cells that are not expressing a protective, this protective protein against cancer. Then a more recent paper from published in 2021 also showed that double break DNA cats may lead to a phenomenon called chromotrypsis, that basically it's a phenomenon that starts with a double DNA strand break, but then expands in a cascade of mutation that can lead to in the area of the double strand cat, but also lead to production of mini chromosomes and genome instability. So we don't know if this is going to be a major problem in these trials, or only time will tell us, but I think it's important to keep aware of this potential limitation. So I would say that in general, I think it is now a reality that gene addition or gene editing or genome editing can modify hematopoietic stem cells to cure diseases. And I'm here listing a variety of diseases where many patients now have been treated and cured. However, we are still facing major limitation. One is, for instance, that hematopoietic stem cell cannot be easily manipulated or expanded ex vivo. So there is very little control. You need to get the cells from the patient. You need to expose them to the virus or whatever, CRISPR-Cas9 system. And then you need to freeze the cells or infuse into the patient, but there is very little room for further manipulating the cells before the complete bone marrow transplant is achieved. Obviously, hematopoietic stem cells cannot yet be targeted in vivo. And that's obviously kind of considered the holy grail in the field, trying to do gene therapy in a pill so that you can deliver your vector, deliver your tools, and target hematopoietic stem cells directly in vivo. That would be obviously very, very productive and safer for the patient, probably. The current myeloablative regimens are toxic, so we are aware that this can lead to a variety of problems, and I will discuss this in the next few slides. And there's been discussed now if, in particular in sickle cell disease, there is already a background level of clonal hematopoiesis that can lead to MDS and leukemia. And maybe these approaches are kind of exacerbating or accelerating that process. So why I'm saying that? Because in a couple of papers recently, in the trial led by Bluebird, which is basically the most advanced trial right now using gene addition and a vector called BB305, it has been seen that a few patients eventually develop MDS and one also developed AML. So the studies further studies indicated that basically these patients develop MDS or AML, and not because of the insertion of the vector, but likely because of the maybe predisposition of sickle cell to develop this kind of conditions. And this comes out of a variety of studies indicating that maybe in sickle cell there is the chronic inflammatory conditions that may lead to clonal hematopoiesis. In one of the study with MDS, the cells expanded out of in this patient were carefully characterized. There was a vector integration in these cells close to the VMP4 gene, but without disrupting the expression of this gene, and this gene has not been associated with any oncogenesis in the previous studies, and it's not a gene that normally apparently has that kind of function. So it looks like and another thing I want to mention is that similar number of patients with beta thalassemia were treated with the same vector, and there were no cases of MDS or AML so far. So this somehow looks like a very, potentially very restricted to sickle cell disease. So, and I think we need, I like to think about that because it's important to understand what are irrespective of the treatment you're using, the gene addition or genome editing, what are potential consequences, side effects by the treatment, by the system we are putting in place to treat this patient. Just to remind you, in gene therapy, what you need to do, you need to mobilize the bone marrow cells, the hematopoietic stem cells. They are basically collected through apheresis. CD34 cell positive cells are then isolated from any other cell, and they are exposed to, let's say, lentiviral gene transfer or, let's say, electroporation for introducing the Cas9 protein, et cetera, And after this manipulation, the cells are infused back into the patient after conditioning. And so this conditioning is still pretty toxic. I mean, we use busulfan, and the busulfan, for instance, can lead, generally leads to sterility because many cells are replicating, are affected by busulfan and die. And so generally the patient that received busulfan conditional lose their fertility. And busulfan also been associated with increased risk of MDS per se. So these already, it's a way to kind of like maybe exacerbate or amplify potential clones already present into the patient. And what is clonal hematopoiesis? Clonal hematopoiesis is basically a process through which one mutation is followed by a secondary mutation and then a tertiary mutation. And then eventually there's accumulation of mutations such that that single clone expands and becomes predominant in the hematopoiesis in this patient. And there was a very recent paper published, I think a couple of weeks ago by a group in Harvard, indicated here. And they basically, what they did, they look at a large number of people, let's say, and including people with sickle cell disease, not people that were transplanted, just like correlating the number of mutations that are normally associated with clonal hematopoiesis and the age of these people. And basically what they realized is that generally there are more, if you look at people with in the same bracket of age, like 30 to 39 years of age, there are normally more mutation associated to cells coming from the bone marrow or patient with sickle cell anemia compared to people that don't have sickle cell anemia. I mean, the presence of this mutation increases with age. So many of us, unfortunately, we already have some of this mutation, but apparently sickle cell anemia, it does increase the rate of accumulation of this mutation. And so it makes sense that if we introduce on top of these baseline mechanisms that increase the production of mutation, the incidence of mutation to this mechanism that we may even more select cells for survival, we may actually exacerbate this phenomenon. So what we would like to improve based on all this information when we think about gene therapies, well, in looking at gene addition, we may want to increase the power of the vectors in expressing hemoglobin. This because obviously, if we can decrease the vector copy number, we would decrease the chances of random integration and oncogenesis, although this is not being seen yet in thalassemia, sickle cell anemia. And of course, if we can modify the system to achieve no random integration, would be also very, very powerful. Genome editing, especially for base editing, we need to improve targeting quiescent cells. Hematopoietic stem cells are very quiescent. And then reduce potential genome toxicity, assuming that there is a potential for that also with this approach. And for both these approaches, obviously, we want to improve or prevent the toxic effects due to the myeloablation and reduce the manipulation of hematopoietic stem cells and the repertoire of hematopoietic stem cells. And as I mentioned before, in vivo gene delivery, a safe in vivo gene delivery without obviously affecting germinal cells would be very, very powerful. So in my lab, I'm going to briefly show a couple of publications from this year where we try to modify lentiviral vectors to increase the power of the expression of the therapeutic gene. So this is a paper. Laura Breda is the first author of this paper, and this is basically very summarizing slides. It's published, so all the data are available. But this is basically a summary of what we did. So we basically generated a variety of lentiviral vector all expressing the beta globin gene. But we modify what I call the software. So we use a different portion of the locus control region, different size of the promoter, etc. And we screen these vectors for expression, and we identify the vector that express among all these new vectors, the vector express the highest level of hemoglobin. And then in the following analysis, we compared our vector to vectors that already been used in clinical trials, such as the vector called GLOBE, done in the clinical trial in Milan, the vector called TNS9 that's been utilized at the Memorial Sloan Kettering, and the VB305 that's been utilized in the Bluebird trial.
Stefano, I want to stop you for a minute and invite John Phillips to unmute and ask his question.
Please.
So, Stefano, what level, a lot of the mitigation of sickle cell disease is, reducing sickling so that it's not a problem. What level of correction of the genotype is necessary in order to see a correction of the phenotype?
Yeah, so that's a great question. I think that in sickle cell, you want to dilute if you're doing gene addition, you're not reducing the expression of the sickle beta globin, right? So you need to dilute that as much as possible. And I would say, historical data say 20% or more. I think it's probably higher than that. But the other key, I think, is also to be sure that you introduce your vector in the majority of hematopoietic stem cells, because just paradoxically, let's say that you were able to introduce 2 copies of the vector, only 50% of the cells, and the other 50% don't get the vector. Even if those 50% of the cell are going to be corrected, I don't think that would be completely successful, because you're still going to have a 50% production. Even if this is maybe not proportionally equivalent in making 50% of red cells the sickle in circulation, you're still going to make some of those red cells in circulation. And I don't think it would be an improvement, but not perfect. So I think you need to have at least 1 or 2 copies, but well distributed in the hematopoietic stem cells. And depending if you're expressing gamma globin gene or beta globin gene, the amount of therapeutic protein you need to make is probably maybe different. I suspect for gamma, maybe a little bit lower than beta. But I would be happy with 30% or more, I would say.
And so then, when you think, on your previous slide, you had like all of these things to sort of improve everything. So are you aiming to get all the improvement out of one change, or are you looking to make, get a 5% change here and a 10% change there? And I'm trying to think of this.
So you will see in the next couple of slides, the most mature approach is this one that we have in my lab right now. And anticipating that we're submitting an NDA hopefully at the beginning of next year to start the clinical trial with our vector. But in the following slides, I will show you what potentially is an additional approach that may be even more powerful. But we are a little behind with that. The goal is really to dilute as much as possible I wouldn't say the problem, there is a large problem in thalassemia in the sense you really want, basically, there's no expression there. So you want just to, accumulate more beta globin chains, right? Because there is a deficit. In sickle, you really need to dilute. And I think the power of the vector is really the key. Of course, you can compensate that, with 3-4 copies per genome, right? It's doable. But I'm a little bit concerned that with that level of gene transfer, you may start seeing more genome toxicity. And so I think the vector should be powerful enough specific, like only erythroid, etc., but to be curative with 1-2 copies. I don't know if I'm addressing their question. But
Yeah, no, that's exactly what I was looking for. Yeah.
Okay. Okay. Thank you. So just to conclude this slide, basically what we did, again, we did all the screening in using a variety of cell lines where the beta globin gene was mutated, where using patient cells from sickle and thal, the mouse model of thalassemia, and intermedia. And basically all this data, cumulative data, indicated that our vector that is indicated as LS20, now we basically documented that makes between 40% and 150% more hemoglobin or beta chains than the 3 vectors that I mentioned before. And so I think this, for me, that's important because I don't want to just go into patients and providing a new vector that we don't know if it's going to potentially better than another vector, or is not potentially more curative. I think, that would be just, a dry and maybe non-ethical approach, because why to propose something that you don't know has a potential to be better? But that's my personal take on that. So another piece of information from this vector that I want to show that's I found it very, very interesting is we actually introduced this vector also in mice that are affected by beta thalassemia major. So these animals don't make any beta globin gene. And you can see here, this is a HPLC profile from a vector mouse that was treated with BB305. With roughly 6 copies. You can see makes 8 grams of hemoglobin, 9 grams, perfect peak. With our vector, we can get to 15 grams with less copies. And you can see that, I would say both are potentially very therapeutic, but also at the level of splenomegaly, the BB305 improves splenomegaly compared to untreated mice. But our vector basically leads to a spleen which is identical to the spleen of a normal mouse. And splenomegaly is one of the features in thalassemia, in case people are not familiar with that piece of information. So another approach that we published recently is actually, we took advantage of targeting BC11A. As I mentioned before, BC11A is important for the repression of the gamma globin genes and activation of the beta globin genes after birth. However, as been shown by really beautiful work by groups in Europe and Dan Bauer and Stuart Orkin, and here Gerd Blobel at CHOP, that if you block BC11A, you can reactivate the beta globin chains and then basically reverse this relationship between beta and gamma globin expression. And so basically the goal is how can you suppress BC11A using a gene addition approach. So for that reason, and I just want to also mention that the work done by David Williams very, very nicely show that with a lentiviral vector that blocks BC11A, it can actually reverse this. And so that's it's been already been successful in patients with sickle cell anemia. So our approach is slightly different. What we did, we embedded a microRNA that for BCL11A in the intron of the beta globin gene. And so with this approach, we basically try to suppress, first of all, BCL11A only in erythroid cells because the vector is erythroid specific. Obviously increase the production of fetal hemoglobin, which is potentially very curative in sickle. Due to the nature of the regulation of the beta gamma globin gene and the looping of the LCR, as you increase expression of the gamma, you decrease the expression of the S. So then you're diluting it's not just a gene addition because you're also diluting and reducing the expression of the S. And of course, the vector is also making a curative hemoglobin A. And so I call this a fourfold effect. So be aware that this paper was published with a vector, not LS20, but a vector that it was started earlier that we identify LS20 with a vector that express much lower level of beta globin gene. So I think that potentially we can get higher level when we transfer this system in the LS20, which is more powerful as a vector. But the bottom line is the following. If you take sickle cell disease erythroid-derived cells, and you treat them with this, basically a vector that only express the beta globin, or the vector that express the beta globin plus the microRNA, you can see that the combination makes more hemoglobin in terms of addition of hemoglobin A plus hemoglobin F in these cells. I mean, a significant difference. And so we are hoping that when we transfer the system in a vector that's able to make even more RNA, hopefully we can bump these at even higher level, but we think this is already potentially quite powerful. So let me move now to the unpublished data, which is related to our new work on alpha thalassemia. And so I want to introduce alpha thalassemia because I think when I talk with people about alpha thalassemia, I think there is a lot of confusion. I was confused myself, so I'm not blaming anybody, but I think there is very little knowledge about the complexity of this disease. So, the alpha globin gene is embedded in a chromosome where the locus is basically surrounded or even embedded with a lot of housekeeping genes. There are definitely hypersensitive site indicated as MCSR1 or 2 or 3 or 4. They're similar somehow to the LCR of the beta globin gene, and they are definitely absolutely required for expression of the alpha globin gene. However, there are no definitive studies so far indicating what are the minimal elements of this region, including MCS and maybe also outside region, that could be sufficient to express the alpha globin gene at high level in a transgenic line. In addition, what I want to also stress is that in alpha thalassemia, most of the patients have have deletion in the alpha globin gene. So for instance, what is called the minus alpha 3.7 or minus alpha 4.2 derives from basically recombination between the meiosis between basically two chromosomes, such that basically the one alpha globin gene is deleted and the other one is embedded in a new region of 3.7 kb or 4.2 kb. And so one gene, alpha globin gene expression, is preserved, but the other one is completely lost. Then there are another subset of deletion called C or MAD, because we're identifying the Southeast Asia or Mediterranean region. And in this case, all the alpha globin gene are gone and a complete deletion. Then there are obviously additional deletion and very complicated because some of them lead to unstable alpha globin chains. Others are stable alpha globin chain, but modify the oxygen affinity of the adult hemoglobin. Other mutations are really affecting the stability of the protein or the RNA. Like the T-Saudi is a mutation in the poly-A, and this RNA is expressed at very low level. And basically in alpha thalassemia, you basically, generally you have, if you have 3 functional alpha globin gene, you're a silent carrier because, we have 4 alpha globin genes normally in our genome. If we have 2 functional alpha globin gene, we have alpha thalassemia trait. If we have 1, and in some cases, 2 alpha globin gene that mutated in a specific situation, we have hemoglobin H, which is basically an excess of beta globin chains. And then if we have no functional alpha globin gene, we have the Bart's hydrops fetalis, which is normally lethal in utero, but now some of these children can be rescued by a neutral blood transfusion. And HBH disease can come with a milder form of anemia and problems, but some of these patients, many of these patients eventually became transfusion dependent. So the other things I want to stress is that we are not very familiar with alpha thalassemia in the United States because we don't have a lot of patients. But if you look at the distribution of alpha thalassemia, let's say in Vietnam, Thailand, Southeast Asia, China, this is very prevalent. Up to 50% of people may be carriers of alpha thalassemia. And underestimating studies, because in this country, there are not yet very good data to report how many patients there are. But basically, there is an estimate that roughly 70,000 children are So I think alpha thalassemia is a neglected disease. There are limited studies. I check on the PubMed, less than 10% of all hemoglobinopathy studies refer to alpha thalassemia, and most of the studies are just reporting the mutation. There are very, very few studies that really look at basic mechanisms or try to erythropoiesis, iron-metabolism, or try to develop new therapeutics. There are no severe mouse models of alpha thalassemia.
Stefano, we keep losing you. I'm not sure what's happening. Looks like you're frozen. Is anybody else seeing that?
Yes, please.
Oh, it looked like you were frozen for a minute.
Okay, can you hear me well now?
Yes.
Okay, good. So the gene therapy approaches are limited by the fact that most of these patients have large deletion. So the only way really to try to treat this patient, I think for now, are gene addition, or maybe the approach that Doug Higgs is undertaking by trying to reactivate zeta globin. So the questions that we are trying to address in the last few minutes is, can we generate a new mouse models to study this disease? And can we apply gene addition to really treat this disorder? So as I mentioned before, only a few mouse models are available to study alpha thalassemia. But for instance, this model has a deletion of the alpha-1 and alpha-2 gene such that these are knocked out on one chromosome, but they still carry two alpha globin genes. And the phenotype of these animals is very mild. So there is no reason to do gene therapy on these animals. But we basically decided to cross these animals and identify fetal liver cells at around 13, 14 days of gestation that derive from complete knockout of these alpha globin genes. Then we basically introduce these in normal mice after myeloablation and follow them for their phenotype. So, and the bottom line is that this worked very well. So this is, for instance, a reverse HPLC that looks at single chains. You can see this in a normal mouse or transplanted with normal fetal liver cells. You have the alpha mouse and the beta mouse. This is a mouse roughly 6-7 weeks, between 6 and 8 weeks. Now we have 30 mice generated like that. They all show the same phenotype. And you can see that pretty much all the single chain is now beta. This is a Western blot showing that, again, we see very little level of the alpha globin in these animals from erythroid cells. If you look at the tetramers, this is again a normal mouse showing just adult hemoglobin. And this is one of the mice we generated. You can see that majority of, this is probably overloaded in this case, but the majority of hemoglobin is hemoglobin H. So again, corroborating the presence of beta chains. So these animals show a very high level of erythropoietin. Obviously, they're suffering by some level of hypoxia. However, and this is very, very interesting, and I'm happy to get feedback from people, these animals don't die because they don't make red cells. If anything, they have much higher hematocrit and RBC production in circulation than normal mice. So this is a very interesting feature. However, the red cells are really bad. So this is just the quality of these red cells compared to normal white cells, and you can see that they really show a variety of features: anisocytosis, poikilocytosis, hypochremia, etc. So these cells show a lot of precipitates of the beta globin chains on the red cell membrane. You can see in a wild type, you don't basically see any beta. This is there's no sample here, and these are basically 3 knockout, at least fetal liver cells engrafted. The oxygen affinity of these red cells is extremely high, so that basically they don't release oxygen. The splenomegaly in these animals is very, as expected in a way. And the erythropoiesis is quite interesting. So these are these are normal mouse. This is the bone marrow, and this is the spleen. So this is a normal profile going from progenitors to mature red cells. And you can see in these animals, they do make red cells, but they are very heterogeneous. It's very similar to what I show you in the peripheral blood smear, so that they make red cells, but they are really heterogeneous in size and qualities. So the mice show also strong features, such as like they lose the architecture in the spleen. There is no germinal centers. They don't have a lot of iron in the macrophages in the spleen, but they have a lot of iron overload in the liver. And this is absolutely in line with the fact that these animals show very low level of hepcidin, so such that basically macrophages don't retain iron, but a lot of iron goes to the liver. They also show very interesting features about coagulation, vasocclusion. I'm not an expert. I've been collaborating with people here at CHOP that really do this very well. This is a lung section, and we're planning to do many more organs analysis. But this, just to make a long story short, the bottom line is these animals show a lot of vessels that they show a lot of aberrant erythrocytes and the occlusions, and they show many of the features associated with coagulation and vasocclusion, such as fibrinogen, formation of nets, really interesting features. So, and the last part of my presentation, I'm going to basically talk about the rescue of these animals. This work is in progress, but it's already very promising. So we repeated the exercise of basically, defining the best vector. But how we made a vector that express the alpha globin gene, if we don't know what are the elements or the basic elements or the minimal elements that can express the alpha globin gene at high level. So in this case, what we decided to clone the alpha globin gene, intron exon UTRs, under control of the beta globin LCR, beta globin promoter, and beta globin enhancer. And basically, we test all these different vectors, again, in a variety of systems, and I show just the data for the vector we think is the most powerful and the most promising one, which is LS20 alpha I, because also contains an ankyrin insulator. And this is data in male cells. So this is basically the proportion of this hemoglobin made by human alpha. So this vector carry the human alpha globin gene. And beta mouse, because the male cells obviously have the 4 alpha globin gene, mouse alpha globin gene, plus the mouse beta globin gene, and now introducing an additional alpha globin gene in their genome. And this is the proportion between this hemoglobin, alpha human beta mouse, per copy number. And what is really interesting is that one copy of this vector in male cells makes 20% of the total hemoglobin, which is in line with the fact that if we have now 5 copies of the alpha globin gene in these cells, you would expect if any gene is expressed in the alpha globin at an equal level, that this vector will make 20% of fetal hemoglobin, of total hemoglobin. And so we also did the analysis in UDAP cells. These are cord blood-derived erythroid cells. We generated by CRISPR-Cas9 complete knockout of the alpha globin genes. And to make a long story short, these are the parental UDAP cells that make hemoglobin A and hemoglobin F. This is one of the clones that were isolated, and we sequenced all of them. And so they definitely don't have the alpha globin gene. And they make only hemoglobin H. And this is one of these clones after introduction of our vector. And you can see that now there is clearly expression of hemoglobin A, F. And in this case, obviously, we still see some level of hemoglobin H. So, but again, doing all the calculation and trying to compare to, the expression of different hemoglobin, et cetera, the bottom line is that even in these cells and different clones, and these are 3 different clones, we basically were able to define that one copy of our vector is able to make as much alpha globin as that one single endogenous alpha globin gene can make. And so we think this is very powerful because most of the patient with hemoglobin H, they only have one functional alpha globin gene, But if you add the second copy, you can move from being like, severe hemoglobin H to almost no phenotype. And this is just interesting. Even the UDAP cells, you can do the studies and looking at the different oxygen affinity, and you can see that the clones that have no alpha globin gene have, again, a completely different binding affinity compared to the endogenous, to the wild type cells. So to treat the mice with our vector, we decide to take this approach. So instead of starting from the fetal liver cell, now we started from the mice that already have alpha thalassemia. So these are CD45.2 cells engrafted in CD45.1 mice. And so we take the bone marrow from mice that have more than 95% donor cells. We still make sure that we beat the cells, we eliminate those potential CD45-1 cells, and then we split these cells in two parts, plus minus the vector, and then we engraft it again in CD45.1 recipient mice. And the bottom line is the following. In a few animals we generated so far, with the vector copy number around in the 0.5, we can see a good amount of hemoglobin. This is the normal hemoglobin. This is hemoglobin H still present. And this is just a historical example shown before of a mouse that is engrafted with no vector, of course. And you can see that there is a very different relationship between hemoglobin A and hemoglobin H. We can clearly extend the lifespan of these animals. But this is a one mouse that received 1.4 copies of the vector, where the majority of the hemoglobin is now considered curative. And we sucked this mouse after 4 months because we were curious to see. And so he didn't die in our hands. So we had to basically decide where was the terminal endpoint. And the bottom line is that these animals has basically normal level of hemoglobin by CBC. The quality of the red cells is improved, and this is wild type, and this is the historical control. And the spleen is completely normalized. I have to say also that pretty much all the CBC values are normal, except for reticulocytes are a little bit elevated. And I think that that means there is a compensatory production of red cells, but it's not associated with anemia. So I think we are in the range of curative for this model, but maybe getting closer to 2 copies will be completely curative. The pathology is also improved. So you can see there is a germinal center here, red pulp around it. This is historical now knockout mouse. The iron is back in the macrophages in the spleen, and it's out from the liver. And then it's again, because in this mouse, I'm not going to show you the raw data, but basically the hepcidin levels are definitely in the normal range. And we have also have few patients, cells treated so far. This is a specific sample that has 3 deletions of the alpha globin gene. And the ratio between beta and alpha was 6 in this patient compared to a normal sample. And after insertion of 1 copy of our vector, we basically decreased this ratio to 2, almost normalized. Basically, I mean, with a little bit higher copies, probably equal to 1. The interesting part is that the hemoglobin H in this patient was not very high, roughly 10%. But with 1 copy, we were reducing this to 50%. And I'm happy to discuss why maybe in humans, the hemoglobin H, although this patient only has 1 alpha globin gene, is not so predominant, but it's something that I also get feedback from people. And so this is basically before my last slide. I just want to point out that there are interesting things happening in the field of gene therapy. But I also want to highlight that there are many things that we think we can do and we should do to improve these trials, such as targeting the hematopoietic stem cells in a way that's less toxic, myeloblative, and hopefully target these gene therapy tools directly to the hematopoietic stem cells in vivo. That would be fantastic. And of course, this is a summary slide also, I think, for just a more philosophical discussion, but and which I think it's important, especially people like me working in this field, like considering the benefit risk, especially in sickle cell patients, and improving communication with the patients. It's important to make them aware. For instance, sickle cell, there are patients that really have no options. They definitely, without the bone marrow transplant, they would probably die, succumb to the disease very quickly. If they don't have a donor, what is the best thing to do? And so we should inform the patient so they really understand and make an informed based decision. Anyway, so these are many topics that we can discuss. I'm happy to get feedback from you. And I want to finish mentioning again that Laura Breda worked mostly on the beta globin project, and Max Chappell on the alpha globin project, and I'm happy to address any question.
Great, thank you, Stefano. I want to invite people to either post in the chat or to just unmute themselves if they have questions that they would like to ask Stefano at this time. I'm watching to try and see if things come up at all. So you think they're just making more red cells because they're not carrying the oxygen well or delivering it well? They're making more of those immature ones in the alpha thalassemia?
Yeah. So I think this is a fascinating aspect. So for instance, right now we are making, so the problem is, initially thought maybe the beta globin chains don't precipitate as much the alpha globin chains, right? But in reality, they do precipitate, very well. I mean, we see a lot of them. So the question is, I guess the next question is, what is the nature of hemoglobin H in mice, and what is the nature of these precipitates, right? Compare at the alpha globin precipitates, and it's just a difference between between beta thalassemia and alpha thalassemia, or there is also a difference between mice and humans, right? So for instance, in order to address this, we're actually generating a mouse right now as we speak, a mouse that will have alpha thalassemia, but only expressing human beta chains. And so hopefully that will address if we're going to see very similar phenotype, or, like more ineffective erythropoiesis, like, that we don't see now in mice. And so then the question is why the human beta mouse and human and mouse beta chains are different.
Well, it'd be interesting. Any other questions? I don't see any coming in the chat. Yeah, so let's just, does anybody want to unmute?
I was a little curious. This is kind of tangential because this is related to some of the articles you were sharing related to the, pros and cons of these types of therapies. But these gene mutations that happen in sickle cell disease, do we kind of have an idea of what's initiating that? It's, following stem cell transplantation, it says, but we typically think of these, cancer drivers as being a survival factor for the tumor. So do they already have cancer predisposition, or is it specifically something driven by the stem cell transplantation?
Yeah, so first, I'll give you some information, and I'll try to pull out a sensible answer to this question. I don't think there is a clear answer, but so let me tell you first of all, in atherosclerosis, where there is a chronic inflammation, there's a clear relationship between inflammation and a clonal hematopoiesis. So the reason I'm saying that, because in sickle cell, there is also chronic inflammation, right? So maybe the two mechanisms are together. So you don't really need a bone marrow transplant to develop this mutation. But I think that bone marrow transplant may, basically you take all these cells out of the patient. You lose many of them, right? Especially with the CAR T technology, the electroporation, you lose so many cells. I mean, what you get back is still sufficient to transplant the patient, but I can imagine how much stress the cells could undergo through, right? So that process, if you already have some mutation, you may be accelerating that selection. So I think that there is potentially already a mechanism in the sickle cell present, but as you kind of manipulate the cells in a way that you favor, survivor, so, cells that can survive in stress situation, you may, accelerate that process. I think that's what's happening in sickle cell. So I think this is, the question is, should we screen the patient that already have some of these mutations? And so the graph I show you, it's really in patients that were not transplanted. These are just sickle cell patients aging, right? Compared to normal aging population. And so clearly, at least based on this paper, there are differences, right? So I think this is a key factor to consider in this kind of trial, especially for sickle cell disease. And I don't know if I addressed your question, but No,
that was great. Thank you. I'm just going to pitch myself here. I've been really studying for the last 2 years how different P53 mutations are impacted by changes in iron availability and how iron availability impacts their function. And so we have a lot of phenomenal data if anybody's interested in helping me put that into a disease model.
I mean, the question is, I don't know, are your studies in humans or also in mice or both?
I think you kind of blurred out.
Oh, so your studies are in humans, in mice, or both?
Human cancer cells. So we're still in vitro. Yeah.
Because I think one of the problems in sickle cell humans is the lifespan. I mean, unfortunately, these patients don't live long enough sometimes to really show the effect of clonal hematopoiesis, right? And in mice, they only live a couple of years if you're lucky. So I don't, you see what I'm trying to say? I totally think that iron has a role in the toxicity and driving this mutation, etc. I just don't know if, because of the longevity of the mice, even with a severe disease, it's easier to really define, the mechanism, associate the mechanism to tumor regeneration. Maybe you need to, I guess, in the past, I was talking with people like, crossing, P53 knockout mice with sickle cell or other things like that, or thalassemia or other mutation that just, exacerbate the story, and then see if the P53 alone versus thalassemia show like a different rate of mutation. I mean, I'm purely, it was just a conversation I had a few times, but it would be fascinating, I think.
Absolutely.
One last question, if there is one.
Me.
Do it, John.
So Stefano, if I understand everything correctly, one of the things that you were screening for essentially was the strength of the promoter. Right?
Promoter and LCR. So the combination of these things.
Right.
We actually work on the introns also. The introns apparently have a role in also determining the stability of the RNA and the expression. So it's not just one factor.
Okay. Because essentially that was going to be my ultimate question is, why not just put some well-established, super productive promoter? Well,
so if the vector were, if you could clone 20 kb or 30 kb in the vector, that would be no brainer, right? You, as much as you can, and then you express the beta globin at a very high level. The limitation is obviously as you add more and more things, then basically you're losing titer, right? Or you're losing pieces. So that's the trade-off, right? You need to get as much expression without, breaking the barrier of not making vector, basically. And so the promoter itself, there are studies done with 2 different promoters, and each paper say this is the best size promoter, right? And at the end, you really need to. I like gene therapy in a way because it's like the way to really double check in real life what is working and what is not. But unfortunately, it's very empirical.
And so I guess in that we now have the ability to target a construct to a specific locus? Are there people that are out there that are, rather than targeting to a globin locus, they're actually targeting in front of some known gene that's highly expressed in red cells?
So, I mean, with lentiviral vectors, there is no technology yet to deliver your vector where you like to. It would be
But with CRISPR there is, right?
yeah, well, yeah, with CRISPR maybe. But you know, at that point, honestly, if you're really trying to introduce a vector in a different locus, but you can fix the beta globin gene, I would fix the beta globin gene.
Okay, got it. Thanks.
Okay, I want to thank everybody for their attendance, and Stefano, thank you for a great presentation.
Thank
Very
you.
thought-provoking. I hadn't heard the malaria vaccine thing, so I got to go read that in the New York Times. And it's so nice to see everyone, and look forward to seeing you again. Thanks again.
Thank you. Thank you, everybody, also for the people in the chat.